and we can move on to the next session, that is young endosonographer. And we have got a 7 presenter who is going to present their interesting case. So for that, I will invite chairperson Dr. Sandeep Laktakia, Dr. Vinay Dheer, and Dr. Rajesh Puri, myself. And I would like to thank the previous speakers and previous chairperson to give the valuable time on the Sundays when they have their family time. I'm thankful to Dr. Roy, Dr. G.S. Lamba, Dr. Nikhil Mahajan, Dr. Siddharth Srivastava, an entire galaxy of the panel, right from Kenneth Bin Moller to Dr. Vipul Rathod. Thank you for giving the very good inputs. Thank you.
Thank
And
you.
we can start the next session.
Thank you.
Thank you. All the young endosonographers are online. I have a request to all young endosonographers, that is Dr. Chalapati Rao, Dr. Gaurav Chawla, Dr. Yogesh Sastry, Dr. Pankaj Jakaria, Dr. Sarat Chandra, Dr. Nikhil Santhalia, and Ankit Dalal, and Dr. Saurabh Mukhewar. We have written in our email also, it is a 4 minutes video presentation. I request you all to stay on time. I don't want to intervene. So my request is the history part can be verbally spoken and video should be shown. If you finish in 3 to 4 minutes time, we will be able to ask the question. It is a sincere request to everyone. And I request Dr. Sandeep and Vinay to start the proceeding. We can, Manoj Sahu is not here. We can start with Dr. Chalapati Rao.
Good morning, everybody. Chalpati, you're on.
Yeah, good morning, sir. First of all, I would like to thank Dr. Rajesh Puri, sir, and the team for giving me this opportunity to present. So I'll share my screen. My screen is visible?
Yes, it is. Please go ahead.
Right. So I would like to share one of my case where we did EUS guided cystogastrostomy using a cautery-assisted biflange metal stent made indigenously using a freehand technique.
There's some background noise coming.
Yeah, I'm not able to move my slides. Just a second. Okay, so I have no disclosures, no conflict of interest. Sorry. Right. So my screen is visible.
Yes,
As a request, you have a 4 minutes, so you should be quick, please.
Hello, my screen is visible.
Yes, go ahead. Go ahead. We can see it.
Okay, so 25-year-old male presented with acute gallstone-related pancreatitis 5 weeks ago in the first week of November, and he was diagnosed to have acute pancreatitis with more than 50% necrosis, with CTSI 8/10. Initially, was managed conservatively. He had pain, abdomen, and acute respiratory distress, and he was discharged in 2 weeks. But after around 3 weeks later, he presented with abdominal distension, pain, and early satiety and vomitings. And CT showed this time a 21 into 14 centimeter walled-off necrosis in the lesser sac, and we planned for a EUS guided cystogastrostomy. A cautery-assisted biflanged metal stent was used with dimensions of 3 centimeter long and 16 mm wide, manufactured by J Mitra company from India, and it was used for drainage using a freehand technique. So this is the specifications of the stent. It comes in a 10.2 French delivery system with a cautery assisted tip as depicted in this pictures. So this is a large pseudocyst, the wall of necrosis actually in the lesser sac, and we can see on EGD an impression along the lesser sac. We initially did a diagnostic evaluation. There is a large collection with some amount of debris amounting to up to 15 to 20%. And on EUS, it was measuring around 11 into 15 centimeters. Predominantly, it has a liquid component. And using the Doppler, we have chosen a Doppler free area. And this is the stent delivery system with direct freehand puncture. We used autocut mode to enter into the cyst. And then we can see the opening of the distal flange as flower shaped, and then we started pulling the catheter out towards the probe. So we were new to this system, so we were not very sure about the delivery. So we couldn't attempt to deploy the stent within the scope. So we had to use the marker under endoscopic vision. So there is an orange marker we can see. And then slowly we started pulling the scope back to deploy. And then we can see that the contents from the pancreatic fluid collection started flowing down. This is the endosonal view of the deployed stent, fully deployed. You can see the fluid which is flowing down into the stomach. And this is the final deployed position of the stent. So this is the final position of the stent. So the procedure duration was around 6 minutes. Pus culture showed Pseudomonas aeruginosa, and we gave him cefepime and amikacin for a week time, and he improved and discharged. So the plan is to assess him at 3 weeks with cross-sectional imaging and exchange with plastic stents. Thank you so much for your patient listening.
Thank you, Chalpati. That was a nice presentation. So do we have questions now or in the end? Rajesh?
We can ask one question, Dr. Sandeep.
Okay. Okay. Chalpati, that was a nice presentation. How did you get the culture? Because it's a freehand technique.
Yes,
You're not functioning with a needle and aspirating.
Right. So there is a port there. So first we have used the same technique as initial 19G needle puncture, what we do regularly. So we connected a syringe to the port, and then we aspirated, and then we sent it for culture, and then deployed this stent.
Okay. Was there any buckling at the time of placement? And this is the first one I've done, or we have done few more before?
We have done the cold stents before, sir, but this is the first hot stent. There is no buckling. Though it is a 10.2 French delivery system, it went smoothly with a single poke. Yes.
Okay, because the wall was very thin, and that's why it makes it easy.
Probably, yes.
If
sir.
the wall is a little thicker, sometimes there can be a challenge.
There will be a bug.
But nevertheless, it was a very good presentation. Thank you.
Thank you, sir. Thank you.
We can invite second one.
Yeah, we can
Who
move to
is
the
second? You only tell na, Rajesh.
Dr. Gaurav Chawla.
Good morning, sir. So I will just.
Can we move to the third till Gaurav will set up his thing? Is that okay?
I think so. Let's do that.
So Dr. Pankaj Jakaria, are you ready?
Prakash, please go ahead. Prakash Zakaria.
Prakash, sorry.
Prakash, yeah.
I'm extremely sorry.
Good morning. I hope.
Yes, visible.
Endoscopic ultrasound-guided gastroenterostomy has been demonstrated to be a safe and effective method to bypass gastric outlet obstruction in patients who cannot undergo surgery or enteral stent placement. For this procedure, a distended and stable small bowel loop is required. Various techniques have been described for EUS gastroenterostomy, including assisted EUS GE technique, EUS guided balloon occluded GE bypass, and direct EUS GE technique. We describe a balloon occluded EUS gastroenterostomy using a modified nasoenteric tube. This is a 12 French tube with 4 ports, 2 for balloons, 1 for injecting fluid into lumen, and a central port which has a hollow stylet through which a guide wire can be passed. The 2 balloons have a capacity of 40 ml and the distance between the balloon is 10 centimeter. Fluid can be filled only in the space between the 2 balloons as the luminal port is proximal to the distal balloon. we describe the procedure in a patient who had gastric outlet obstruction. This is a 68-year-old male who had gastric outlet obstruction due to metastatic malignancy of duodenum. Upper GI endoscopy done showed obstruction extending from first part of duodenum. A guide wire was passed across the obstructing lesion into the proximal jejunum under fluoroscopic guidance. The modified nasoenteric tube was then threaded over 035 JAG wire into proximal jejunum. The balloons were distended with air, first distal followed by proximal. Approximately 350 ml of methylene blue mixed saline was injected into the luminal pot with a 50 cc syringe. With the echo endoscope placed in the body of the stomach, the fluid-filled jejunal loop could be easily localized. The distended jejunal loop was then punctured using a 20 millimeter hot axios, and the stent was deployed in the standard manner. After deployment of the stent, methylene blue mixed fluid was seen gushing out of the stent lumen, confirming the luminal position of the stent. The stent was subsequently dilated to 15 millimeter using CRE balloon. Post-procedure, patient was started on oral fluids the next day. So far, we have done 5 cases with the help of this tube. All procedures were successful without any complications. The modified nasoenteric tube devised by us is effective and safe for balloon-occluded EUS gastroenterostomy. Thank you.
Nice presentation, Prakash. Fantastic case. Congratulations.
Thank you.
I want to ask you one question. What is the difference between your tube and the EPAS tube?
The EPAS tube does not have this metal stillet.
What stillet?
The stylet which goes through the inside of the tube, this is stiff and it can carry a guide wire. So the thing is, this can straighten the tube inside the stomach. So even though this tube is smaller than smaller in length than the other tube, you can very well reach the proximal jejunum.
No copyright violations? Just asking. Don't take it otherwise.
That's I know.
You know, Takao is very possessive about his EPAS tube.
Okay.
What I understood is it doesn't require over tube. In Takao tube, you require over tube, but this is like an NJ tube and
Right.
it's stiff because of the wire. So that will be very easy to insert and the looping will not be a problem in the stomach. I think it's an excellently made.
Very well.
Fantastic presentation and a very nice innovation. I think it's a little different, like all metal stands are slightly different and they're still in the market. I think this can still be there.
So is Dr. Gaurav Chawla is ready or should I invite Dr. Sharat Chandra?
Sir, shall I try?
Yes.
I think it should go now.
Please.
Rajesh, I'll have to leave in 5 minutes. Huh? Sorry about that. I have to give another presentation somewhere else.
Okay. Dr. Gaurav, you can send presentation to us. We can run. So I will invite Dr. Sharat Chandra to present his case. Because of the scarcity of time, Dr. Gaurav, if you are facing problem, you can send it to us. We can run from here.
Okay, sir. Okay, sir.
Is Dr. Sharat Chandra is there? Dr. Sharat? Dr. Saurabh Mukhewar is there?
Yes.
Dr. Saurabh, please. Yeah.
Hi, can I present my case? How are you?
Yes, you can, I think. Saurabh, go ahead, I think.
Okay. All right. Hi, I'm Saurabh Mukhewar. Thank you for allowing me to present my case today. I'll just move forward and, stick to the case in the interest of time. So I have a challenging case of biliary drainage that I'll be presenting today. I'll just make it brief. 66-year-old male with obstructive jaundice from a mass in the head of pancreas was referred for further evaluation and management. This was inoperable. So we decided to start the case and do EUS FNA in a standard fashion with a 22 gauge FNB needle. And following this, we started an ERCP. And as you see, the papilla was pointing towards D3, and it was hard to cannulate. We made multiple attempts, but were unsuccessful. So at this point, we decided to, excuse me, switch to EUS guided choledochoduodenostomy. So the CBD was identified with Doppler to confirm that we are looking at the common bile duct, which was mildly dilated to 12.8 millimeters. And then we get a 19 gauge needle across the duodenal wall into the bile duct, followed by cholangiogram, and then coiling of a 0.025 inch guide wire. And then we get a cystotome across to create the fistula. And then we got the guide wire in position. As you see, it was a little hard to get the position in this case. And then we decided to proceed with Geobar stent placement. And although we've done a lot of successful ones, this somehow, it was just really hard to get the stent across the duodenal wall. I guess the angulation and the scope position was difficult. We eventually got it across the duodenal wall, but then subsequently to get it across the bile duct was more challenging. And I felt at this point I had pushed the bile duct away. And right. So now I'm worried because I have a puncture in the bile duct and I just cannot get it in. And then eventually, as you see, the guide wire is lost and there's free air. So now we decided to switch. Either we could have got an IR route, or I said, let's look at the gallbladder, which is nice and plumb distended. Fortunately, the cystic duct was patent for me. So I visualized the gallbladder, which was about 3.8 centimeters, the longest distance. So across the antrum, I punctured with a 19 gauge needle, followed by a guide wire placement, and then the cystotome to create a fistula tract from the antrum into the gallbladder. I don't have the EOS images because my technician forgot to switch the video, but then we dilated with a hurricane balloon. And then subsequently, we decided to place a Nagi stent. I didn't have a Spaxis in the last moment, so I decided to use Nagi. I guess it still works. And gradually place the internal flange, followed by the external flange right here. And as you see, there's a gush of bile coming out. The stent placement was good. And there's a lot of bile coming out as the system was quite dense. And then we went on to look at the duodenal perforation or the hole we created and placed some hemoclips to close this defect. Just because it was iatrogenic, we decided to get 3 clips in, really make sure that we have a good seal. And then we also confirmed this with contrast to make sure there's no leakage in the peritoneum. And patient had biliary peritonitis, recovered with IV antibiotics, bilirubin reduced to 4 in less than 10 days. Just to highlight, this can be a rescue therapy in patients with failed choledochoduodenostomy. As part of this study, 28 patients, 100% technical success rate, 93% clinical success, few complications, but this can be a salvage therapy. Thank you.
Thank you, Saurabh, for a wonderful presentation. Did you use a 6 French cystotome in the first go when you did a CDS?
Yeah, we use a 6 French cystotome. I suppose I can, but yeah.
Still, the stent did not go in easily.
No, it did not.
Saurabh, can I make a few? I have to rush, so I'll just make 1 or 2 comments on this. I know you have done lots of Great work. But your scope position was looking too much down.
Yeah.
So you had a straight path and then an up path. So you had an almost 90-degree angle, which is
Yeah,
impossible for any stent to surmount. So
I know.
I know sometimes you don't get a good position. It is difficult to get a good position, and
Yes.
then these things happen. But the best way is if it goes straight up rather than creating an angle. You know,
No,
if your wire is hitting the opposite CBD wall and then going up,
yeah,
then
yeah,
when you pass a cystotome and then a stent, you create a 90-degree angle.
correct.
My second comment is Nagi stent has been used for gallbladder drainage, but please be careful.
Yes,
It is not a lumen opposing stent.
right.
Sometimes you can have migrations and you can have problems. So either Spexus or hot Axios, cold Axios
Yeah.
is a better bet. This time it worked well for you, so that's great. But
Yeah, thank
उधर
you.
नागपुर में थोड़ा मंगा के रखो Spexus वगैरह.
I know. It is like 9:30 p.m. late night. I have
I know.
whatever I have in my hand, just put it.
Yes. No, but
But
great. I think you salvaged it very
How
well.
much time has passed after placing the Nagi stent in the gallbladder? Because it can migrate later on when the gallbladder collapses.
Yes.
Are you
Yes.
right,
concerned?
right. No, you're right. So eventually, the patient did fine, but I believe on follow-up he had passed away from his malignancy, but he is not wild.
So thank you, Dr. Saurav. And this is my feeling. I'm not sure, but putting a double pigtail stent might help in prevention.
Right.
The next speaker is Dr. Sharad Chandra. Thank you, Dr. Saurav. Dr. Sharad, are you ready?
I'm ready.
Please go ahead.
Rajesh, you have to excuse me now. Bye.
So investigation showed a total leukocyte count of 17,800 with 89% polymorphs. His creatinine was normal.
The video,
Platelet
can you
count
visualize
and
the video
performance
now?
time was within normal limits.
It now.
His ultrasound lamp showed a large subcapsular heterogeneous abscess involving segment 2 and segment 3 with semi-liquefied contents. Abscess was deep-seated with intervening vessels coming in the path of access to the abscess. A clinical diagnosis of a large subcapsular liver abscess involving segment 2 and segment 3 was made. The abscess was radiologically inaccessible and the etiology likely was amoebic. Patient was started on IV antibiotics and anti-amoebics. Consent was taken for EUS guided drainage. EUS evaluation showed a large abscess involving segment 2 and segment 3 with contents which were predominantly hypoechoic. And there was a very thin rim of preserved liver parenchyma surrounding the abscess. The cavity was accessed with a 19G needle through the transgastric route, and we aspirated around 50 to 60 ml of anchovy sauce pus. However, after that, it stopped draining, and despite repositioning the needle and flushing the needle, nothing came out. So we switched over to transluminal drainage. The steps of drainage was guide wire coiling, following which we dilate the tract with initially with a 6 French cystotome, followed by a 7 French dilator, thereafter with a 10 French dilator. We as a policy always aspirate the contents of the abscess cavity with a 10 French dilator to reduce the pressure within the abscess cavity, which reduces the chances of peritoneal spillage. After that, we deploy a 10 French nasocystic drain within the abscess cavity. Following this, the abscess cavity was actively aspirated with a nasocystic drain. And within 12 hours, initially we did active aspiration, following which it started spontaneously draining out. And in next 48 hours, the abscess cavity collapsed, patient improved, and the nasocystic drain was internalized into the stomach. And after 72 hours, patient was absolutely asymptomatic and patient was discharged. Coming to the discussion, what are the factors which guides drainage? Where we can do aspiration and where we need to do a transluminal drainage. Now, the first factor is the morphology. And then most important is the content of the abscess. If the contents are liquefied or semi-liquefied, yes, we can do the aspiration. However, the contents are predominantly solid or mixed, we have to do a transluminal drainage. Whenever we attempt aspiration, there's always a unpredictability is there. You might not be able to aspirate significant contents of the abscess. Therefore, one should always be ready to convert aspiration into a transluminal drainage. If there's a thin rim of preserved liver parenchyma, transluminal drainage is a better option. There is an indication. Aspiration is only indicated in case of subcapsular abscess or if there is impending rupture. However, if there are large abscesses with suspected biliary communication or they are ruptured abscess, transluminal drainage should be done. Next is the technique of drainage. Like we use a modified technique for drainage and we have what we have done is that we have added the step of active aspiration of the abscess cavity with a 10 French flow dilator to reduce the pressure within the abscess cavity, thus minimizing the chance of peritoneal spillage. Secondly, we always use a 10 French nasocystic drain for transluminal drainage. And with this technique, we have been able to do 5 patients, and we have been able to drain abscesses which had ruptured, abscesses which had very thick contents, and we were successful in managing difficult patients with this technique. In conclusion, EUS guided drainage is a safe, effective, and minimally invasive approach for draining radiologically inaccessible liver abscess. Technique of drainage is simple and can be performed by anyone doing interventional EUS. 10 French nasocystic drain works well for transluminal drainage. Thank you.
Thank you, Sharath, for a nice presentation. Do you irrigate through this nasocystic tube, or just for keeping for drain?
Actually, in this patient, the contents were not very thick and it drained out spontaneously only. Whereas if the contents are thick, you can do aspiration, you can do the lavage of the cavity if the contents are thick and blocking the drainage. So in this case, patient, we didn't require to do anything.
So why not stent alone?
Yeah, actually, stents, there is a lot of unpredictability involved. By chance, the stents get blocked, so we don't even come to know about it. With a nasocystic drain, we always know if it's coming out or not, it's draining. So that if it's blocked, we can even easily flush it. So stents, we always prefer nasocystic drain than stents. Moreover, we can also diagnose any biliary communication if it is there. So NCD is always advantageous over using a stent for drainage.
Are you concerned about any leak from the liver into the peritoneum?
Yeah, actually, what we do is that before placing the NCD, we are actively aspirating and decompressing the cyst cavity, the abscess cavity. This reduces the pressure within the cavity and the chances of spillage become minimal. That's what we have advocated in the technique which we have published.
Fair enough. Thank you.
Thank you, Dr. Sharad. And we will go with the Dr. Gaurav Chawla. Dr. Gaurav Chawla, we are running your videos from this side. So be prepared. Can we start the Dr. Gaurav Chawla slides, please? Dr. Gaurav? Dr. Gaurav?
Yes, sir. Thank you, sir. Thank you, sir. Are you able to view me? Now, shall I speak?
Yeah, please.
A 50-year-old male presented with obstructive jaundice in October 2018, and he had periampullary carcinoma. He was not willing for Whipple's and he required a drainage procedures. We tried ERCP, but ERCP was not successful. So we did a EUS guided choledochoduodenostomy then. Next, please. So this is the images from 2018 choledochoduodenostomy.
Others can mute their mic, please.
This is a periampullary mass there and a choledochostomy done in 2018, and it went well. Patient resolved with jaundice and all his symptoms went. Next. So after 5 months of this, he developed a duodenal obstruction for which he did a duodenal stenting, metallic duodenal stenting, and he was asymptomatic till December 2021. So now he again presented after 2 years, 2 months with obstructive jaundice and cholangitis. So this was the ES evaluation. Can you play this? This is a portal vein thrombosis happening inside the portal vein. And you can see a portal vein thrombosis, and there is a large periampullary mass which will be visible now. This is a periampullary mass with a duodenal stent in situ. This is a now periampullary mass. Here you can see a stent echo of duodenal stent. And what we visualized endoscopically, there was no stent in the choledochorus. SMs has migrated. There was no stent there. Even opening was not visible. So we planned to do a repeat cholecystectomy as there was no ascites. Functionally, patient was normal. He was in cholangitis. So this time we had some problems. This was the puncture site we used. This is guide wire. So once initially, when we were puncturing, the initially wire went down, but with gradual manipulation, this you can see wire going down into the duodenal stent. But gradually with manipulation, we were able to place the wire in the right place. And in spite of that, we were having problems with the tract dilatation. Actually, second step was not happening. Repeated dilatations, it was not happening. Next slide, please. So here you can see that it has went well. The wire went well. Then after the wire, we were able to we did cholangio. Actually, first setting, we didn't do cholangio because we were confident because dilator was not going. Then we did the cholangio to be very sure of what is his. Next, please. Next slide. So this was the problem step. This also I want to play. Please play the first video also. So here, this was not happening. This step was not happening. Our dilator was not. We checked the cautery settings. This is a 6 cystotome. We use cautery dilators usually, but it was not going. Whatever we were doing, then we gradually withdrawed, and the problem we identified that current was not transmitting because this here you will see sharing of wire happened here. So because of this sharing of wire, the current was not going and track was not getting. Here you can see the sharing of wire happening. So, but wire went in good direction, but the step was not happening. So this is the sharing of wire. Then we have to do a repeat puncture next to this site because we already tried twice from this side. So next slide, please. Next slide. So can you play both the videos? Can you play? So this is the, can you play both the videos? So this is the stent, and this now, this is here. If you see the first one here, you can see this was the initial site. We have to puncture here. Here we are able to cross the cautery, and then we were dilate with balloon. And then once we dilated, both the sides almost became one. And here you can see the covered portion. This is a partial covered stent from Boston. Partially uncovered stent from Boston Scientific, 6 centimeter, both the half centimeter uncovered. So then we were able to place the stent also in this case after that. So next slide, please. Next slide. So this was the final position. We were able to pay the stent, bile flow was noted, and everything went well. So next slide, please. Once we did this procedure, once we were withdrawing the echoendoscope, we can see that first video, please. Here you can see a lot of fresh blood was there in this thing. So this fresh blood was there. Then we thought, what is the reason for this fresh blood? There was what we thought that because of this abnormal scope position, minor ulceration with active ooze had occurred, which was oozing actively from this point. So we hemoclipped that with gas. We switched over to gastroscope and then did a hemoglobin, and hemostasis was achieved. The second video, this was after 2 weeks, which showed that that stent was in good position. There was nothing that. So our case was EUS guided choledostomy offered exit palliation at the first place. Migration of stent occurred after 2 years. And we had difficulties in repeat choledostomy. 6 French cystotome was not going because of wire sharing, because of altered anatomy also might have played. Then repeat puncture adjacent to the initial puncture in close proximity to duodenal wall led to technical success. And bleed can occur because of abnormal scone position in such places, and we should tackle it immediately. Thank you.
Very nice case, Gaurav.
Thank you.
Thinking on the feet many times over. I think you were jumping on one feet to the other. Each time there was a problem, you were tackling it. And wire sharing is a common problem with EUS intervention, especially for biliary drainage, and you have to repuncture it. Fortunately, you could enter it again and then dilate it with a balloon and place a stent. And also the bleed which does happen, yes, because of too much scope moving in and out, it can cause friction. Nice case and well done.
Thank you, Dr. Gaurav.
Thank you, sir.
Dr. Ankit Dalal, are you ready?
Yeah.
And is Dr. Nikhil Santalia is there?
Yes, sir.
Okay, so Dr. Ankit is first and followed by Dr. Nikhil Santalia.
Or we move to the next one and then come back to you.
Yeah,
Nikhil, are you ready?
Yeah, I think Dr. Nikhil.
Yes, sir.
Yeah, can you go ahead?
You see my screen?
Yeah. Go ahead, please.
I'm going to thank you, Radheshwar and Sandeep, sir. I'm going to present a case of endoscopic step-up therapy for management of pancreatic VON. My case is of 49 years of male presented 6 weeks after an episode of acute severe necrotizing pancreatitis with pain abdomen, lump in abdomen, and fever. CT scan was showing a VON of size 10 into 8 centimeter in relation to body and tail. We went ahead and did EUS guided Nagi stent placement. Can you see the video moving?
It's a still image. The video is not moving. We still see the CT scan.
So after interrogating the cyst for walls maturity and size and percentage of debris, which was around 15%, inserted a 19 gauge Olympus EZ short needle. After aspirating the turbid fluid, 0.025 VG-glad wire was inserted with 2 to 3 coils for meat. Subsequently, the needle was exchanged for a 6 French cystotome, and pure cut 120 watts was used to create the fistulous tract. Once the tract was created, it was dilated using a 6 Titan balloon. After the dilatation, the stent was introduced, and the distal half was placed under fluoroscopic and EUS guidance, while the proximal half was released inside the scope and then subsequently deployed under endoscopic and fluoroscopic guidance. After the deployment of the stent, we had observed for a few minutes for the adequate flow of the turbid fluid, and wire was kept for a few minutes. Once we were satisfied, we came out, and then patient was managed with supportive care. So initially, for 2 to 3 days after the procedure, patient did well. The pain had come down, the fever had subsided, but then there was new onset of symptoms on day 3 and 4. And a repeat CT scan was done, which was showing evidence of persistent collection with suspicion of stent block. So we went inside and we found that the stent had dilated, the tract has formed, but the opening was blocked by large amount of necrotic material, which was clogged. So we did a declogging using a braided snare. And as soon as the declogging was done, there was gush of fluid coming out, with large amount of fluid being emptied into the gastric cavity, and the whole of the Vaughan cavity appeared to be almost empty. So subsequent to this declogging and decompression, we decided to go in and place a nasocystic tube, which was placed. And in addition to that, we also decided to go in place 7 French double pigtail stents. So after securing the 2 7 French double pigtail stents and the nasocystic tube, patient was again managed conservatively. And then subsequently, irrigation was done using normal saline around 6 to 8 hourly for next 2 to 3 days. Aspirate gradually reduced, fever and pain improved. A repeat ultrasound showed significant reduction. We went in for a Czechoscopy on the day 5 after this procedure, and we could see a almost near complete collapse of the cavity. There were mild adherent debris that we can see, but there were evidence of healthy pink granulation tissue which had already begun to form. At this stage, we decided to remove the nasocystic tube, but we tried to secure the double pigtail inside for any subsequent reintervention that he may require, or to prevent the migration of the lamps of the Nagi stent. So, so patient is currently under follow-up, and we plan to do an MRI 2 to 3 weeks later and removal of the Nagi stent with or without indwelling double pigtail, depending upon the pancreatic duct status. So this case highlights that endoscopic step-up approach, as advocated by Sandeep sir, is quite appropriate for management of these patients. The few questions that I had in my mind, that putting a double pigtail at an index procedure would have prevented clogging in certain patients with large Vaughan which are proximally drained, where gravity may play a role. Should all patients undergo a check endoscopy on day 3, irrespective of symptoms, to look for stent blocks? And whether after declogging, should an NCT be placed after evaluating the cavity for debris, or it should be placed in all patients? So those are the few questions that arise in my mind, depending on the case. Thank you.
Thank you, Nikhil, for a nice presentation. And you're putting more questions in the end than answers. Okay. But that's a way I think a scientist should look into, and a good investigator looks into. And you have very rightly put some of these questions, which also crosses everybody else's mind. It was declogging that he did and not necrosectomy, and that's a wise thing to do. I think one stent and one nasocystic tube generally suffices. Irrigation then cleans it up, and then a relook endoscopy at the end before pulling out NCT generally makes a huge difference.
Thank you.
Thank you, Dr. Nikhil. And is Dr. Ankit Dalal ready?
Yeah, I'm sharing my screen. So if you can see it.
Yes, visible. Please go ahead.
Okay, so I'll just briefly tell you a bit about the patient. So this was a 30-year-old male. He had recurrent episodes of abdominal pain, and he was diagnosed on CT and MRCP to have chronic pancreatitis. The MRCP typically showed.
Can you move your slides, Ankit? We can't see the next slide. We're only in the first slide so far.
I'm trying to. I think there's something stuck somewhere. Yeah, this is the MRCP. So basically, it showed that the patient had a hugely dilated pancreatic duct with a radio opaque calculus in the head, and as well as a tight stricture. So he initially underwent 3 sessions of ESWL, following which he was posted for an ERCP. But we could not get the PD cannulation. There was failed PD cannulation. So that is when we decided to go ahead and do an EUS guided pancreatic ductal intervention. So the initial thought process was to do a rendezvous. If a rendezvous failed, then we would have had done a pancreaticogastrostomy. So I'm just beginning the video. So scanning with the linear echo endoscope, this was a hugely dilated duct with a calculus inside. I was tracing the duct towards the body and tail. The patient was in supine position. Once we had finally found ideal pace for a puncture in the body tail region, we used a 19 gauge needle from Boston and proceeded with the puncture. So there is obviously a difficulty with pancreatic punctures, especially in chronic pancreatitis when the gland is fibrosed, the duct is thick walled, and getting access to the pancreatic duct can be difficult. So you need to make sharp jabs, sharp and rapid jabs into the pancreatic parenchyma and into the duct. So we got access, and as we can see on a pancreatogram that there was a dilated duct in the body tail with a stricture in the head, and there was this stone which was seen. Once guided access, we passed a J-tipped 032-inch Termo glide wire. That is what we use for most of our EUS guided interventions. And we tried manipulating the wire to get it across into the duodenum to perform a rendezvous. But you can see that the stricture was tight. It was difficult to get the wire across. So then we decided that let's dilate the tract with a 6 French cystotome. So then we exchanged the needle with a 6 French cystotome, subsequently, which you will be able to see on the video. And again, the scope position in EUS guided pancreatic drainage is important. As we can see, it needs to be stable, it needs to be pointing towards the papilla. And maintaining the scope position is quite important for success. So what happened here, you can see the scope position changed slightly. Luckily, I had a good loop of wire within the pancreatic duct in the dilated segment, which allowed me to pass the cystotome across. Here we can see that the cystotome has entered the pancreatic duct, and now we are withdrawing again the guide wire, the Termo guide wire, and trying to manipulate it across the papilla. Presence of the cystotome obviously helps give stability, and it acts as a fulcrum for the passage of the guide wire. And with the help of this, we were able to get the Termo guide wire across. Here you can see that the Termo guide wire crossed across the papilla and was looped into the duodenum and subsequently into the stomach. So then we proceeded with the scope exchange. We were gradually pulling out the linear echo endoscope, with the technician is pushing the wire through the channel, and I'm pulling out the echo endoscope, and I'm introducing the side viewing duodenoscope. Again, while doing a rendezvous, it is important that you don't entangle with your wire when you are introducing the duodenoscope to make sure that it doesn't slip out. So constant fluoroscopy as well as endoscopic imaging to make sure that the wire does not slip out. Once we are in the duodenum, you can see that the wire has exited out of the papilla, and you can see the other end of the wire. Other tip. So we grasped it with a rat tooth forceps, the other free tip of the guide wire, and pulled it into the channel. Again, this is an important step. You should not lose. You should maintain a firm grasp of the wire and pull it slowly, with the technician also pushing in the wire from the mouth, and constant fluoroscopy imaging. So we can see we are gradually pulling the guide wire out of the channel and making sure that it does not lose position on fluoroscopy. And we have it outside the channel. The guide wire is successfully secured, and over which we passed in the sphincterotome, and then the routine steps of pancreatic ERCP with the pancreatic sphincterotomy, contrast injection, and then we placed a 7 French stent. So this is what we managed to do in this patient who had recurrent episodes of pain secondary to chronic pancreatitis and a tight stricture in the head of pancreas with a stone with a failed ERCP. Thank you.
Well done, Ankit. It was a nice demonstration of a difficult case. But did you at any time consider surgery for this patient? He had a stricture which is tight and stone disease. Two things together will be a more challenging to tackle with.
Yeah, I know. It was a single stricture and a single stone in the head of the pancreas, although the stone was large. So, and the patient preferred, we gave him the option of a surgical drainage as well, but he preferred to undergo endotherapy first. So,
because as per the pancreatogram, the stone is still big and above the stricture, upstream to the stricture.
Yeah, I know. The stone is quite large. So hopefully we can subject him to more EHWL and crush the stone. Perhaps we can dilate it further and pass in a pancreatoscope and pulverize with holmium laser. So if we can succeed in dilating the stricture up to 10 French, then we can perhaps pass in a pancreatoscope and pulverize the stone.
So thank you, Dr. Ankit. Thank you. And the last speaker, Dr. Yogesh Sastry, and I request, we are 20 minutes late. So please be on time. Dr. Yogesh Sastry, are you there?
Yeah, I'm there.
So please.
So can you see my slides, please?
Yes, please go ahead, Yogesh.
Yeah. So at the outset, I would like to thank the organizing committee and Dr. Rajesh for giving the opportunity. It's a very small case, simple case. I can't move the slide. Okay. So this is a 42-year-old Asian male presented with high-grade fever to the surgeon. The lab shows high WBC count, CRP, procalcitonin suggestive of sepsis. Ultrasound shows mixed ecogenic mass in the caudate lobe of the liver. The CT also shows that there's a big mass in the caudate lobe, which is extending anterior to the pancreas. So it was difficult to do the IR drainage. So the surgeon requested if I can do a drainage for this lesion. So this is the CT scan which is showing the lesion, and this is the EUS. So as you can see, this is the large mass which is in the caudate lobe, and we put in a 19 gauge needle into this mass. So this is the needle which is coming in, and this was aspirated. It was a pure pus, and I could almost aspirate it completely. As you can see, the cavity has collapsed completely post aspiration. So I did not put a drain or anything into that, and just terminated this procedure. This is the bile, and the patient was discharged after 5 days. He was given oral antibiotic and totally asymptomatic. He came for follow-up and 1 month back, and there was total resolution of the abscess. So my aim of presenting this this case was that we always have seen in the literature that they always put a stent into the abscess when it is really big or large. But if you are able to aspirate it completely, there's no need to put in a stent because it has its own consequences, complications. So if you are able to aspirate them, then you can really avoid it, and it's a one-step procedure, and patient can recover from it. So thank you.
Thank you, Yogesh, for the nice case. So we have 2 liver abscesses presentations today. One aspiration, one is drainage. Good.
So thank you all, and I request Dr. Sandeep to give me the name of first three which he feels. And as Vinay is not there, so I will leave the decision to Dr. Sandeep. and he will give the 3 name, and we give a small complimentary gift, whatever is possible.
Okay.
Sandeep, you will send the 3 name.
Okay.
And with this, I will finish this session. I will thankful to Dr. Sandeep and all young endosonographer. And I think the few cases are very good and very challenging also. I'm thankful to all.